Okay, here we go. Buckle up, kids. We've got a lot of information to cover. We're going to change formats once or twice here when we get to looking at 12 lead and the location of injuries and such. We'll go to a different screen and we'll see how all this works out. It's probably way too technical for me, but whatever. We'll figure this guy out. So ischemia, injury, infarction. Remember when we looked at our list of the things we're going to do for 12 leads, one of them was we're going to review for zones of ischemia, injury, or infarction. So to think about the different stuff that we're going to be doing and why we're looking at this, looking for ischemia, injury, or infarction. That has to do with the type of waves that we're looking at whenever we look at the EKG. So you have everything from unstable angina to non-ST elevated MI to STEMI, a lot of different things. But essentially what it all comes down to is that somewhere coronary artery is narrowed or blocked significantly. As you can imagine, when that happens, the tissue is deprived of O2 and nutrients. And by that happening, when it's deprived of oxygen, we shift from aerobic to anaerobic metabolism, which we remember starts creating acidosis. And then you have, once it starts going from injury into infarction, and that occurs when the ischemic process is not interrupted, meaning it's not fixed. So you didn't get, they didn't make it to the cath lab fast enough, or the clot hadn't moved on, or whatever, and you end up getting, resulting in some tissue death. So just as it was when you took your EMT class and you heard the saying, time is muscle, it's still true. Time is still muscle. So we want to make sure that the best thing we can do for this, as we mentions here a little bit, is be able to recognize that this is a cardiac issue and to be able to do something and get them to the right place. So when a coronary artery is blocked, there are characteristic changes in the ECG. So you get a couple of different things here. We're talking about ischemia, injury, and infarction. So for ischemia, we see ST segment depression. You can see that anytime from just some angina or an angina to, of course, up to an MI. ST segment elevation, myocardial injury. Once again, that's going to be pretty self-explanatory. And then a pathological Q wave, which is a sign of infarction. Now, pathological Q wave, it's not uncommon to see a Q wave. It's uncommon to see pathological, which means that Q wave measures out to be about 25% of the height of the QRS. That's what is the big factor there for making that Q wave into a big deal. So, continuing on, the coronary artery is blocked, so you get some ST segment depression, greater than 0.5 millimeters, and 2 or more contiguous. Remember, contiguous leads, I don't know if we've talked about it, I don't believe we have yet. Contiguous leads are going to be those leads that, you make sure you look it up, because I'm probably not going to tell you a very good version of contiguous. But contiguous leads is when you have like 2, 3, and AVF. It's all looking at the same portion of the heart, but from different ways. So 2, 3, and AVF is all looking at the inferior wall, looking at the inferior portion of the heart, and gives you that view. So you need to be able to find it in 2 or more contiguous, I believe it's contiguous, maybe contiguous, but I've always heard contiguous leads in a patient with chest pain or discomfort, not that are not asymptomatic. We're not looking for ST elevation in patients that aren't symptomatic. We're looking at for patients that are symptomatic. And here we're talking about ST segment depression, because remember we started off going from ischemia, and then we move into injury, and then we move into infarction. So ST segment depression greater than 0.5. So if we suspect a STEMI, for leads V2 and V3, the ST segment elevation is 2 millimeters or more in men older than 40. Of course, 1.5 or more in women, and it's elevated 1 millimeter or more in your other leads. So for leads V2 and V3, the ST segment elevation is 2 millimeters or more, and then in your other leads, it's going to be 1 millimeter or more. So non-diagnostic ECG, the absence of ST segment changes. This doesn't rule out an MI, injury or infarction. What really has to happen is that they need to have blood work done to make sure that nothing is evolving right now. So early acquisition of a 12 lead in a patient who may have an ACS is essential. We got to get that 12 lead within the first 10 minutes of patient contact, if that's the case. So this is just kind of shows you the evolution of what you might see on an EKG whenever we're going from ischemia into injury and then into infarction. So we talk about the ST, here's our normal state, and we talk about having some ST depression, as you can see here. Now we start moving into some elevation, right? We're having some ST elevation. You see that's, and where we've got a inverted U wave, or inverted T wave, I'm sorry, as well. Now we start to see we're having a lot of elevation here, and we start to develop a Q wave as well. So you've probably heard these. Right around here is where we start, you might hear the words tombstone T wave. This becomes a real issue here because these guys are not going to do very good as you would expect. And then we get down to where our Q wave gets longer and longer, and now it's turned into a pathological Q wave. But everything else has really kind of returned back to our baseline or our isoelectric line. Hang on one second. All right, so we talked about that. Putting the Q wave in, all the different changes that we'll have throughout. So when we talk about acute coronary syndromes, ACS, and all the things that go along with it, these treatment decisions are all made on the basis of a few different things. Patient's presentation and history. So if they have a cardiac history, then that should be something that kind of, alerts us that something could be going on, as well as how sick do they look? Are they sick or are they not sick? Then we run a 12 lead as well, and that's just another tool in the box. 12 leads do not diagnose MIs. Paramedics, actually, if you're to be in a real anal sense, paramedics don't diagnose MIs, but we can recognize them. We don't need a 12 lead to recognize that. We're able to recognize it without the 12 lead. What the 12 lead is another tool in our toolbox to help these people out. So, and then laboratory tests in the event that you're able to start doing some cardiac labs, which most places aren't doing anything like that, but they will when they get to the ER, right? So, when you guys come in the lab, remind me, and I'm going to hand you guys out some cards that look just like this. So what this is showing you what each lead is looking at and what it's looking at in the portion of the heart. This is also going to be kind of a place where I show you how we can break these 12 leads up so I can help you to diagnose whether it's a lateral or inferior or if it's a septal or anterior MI. And then we'll apply it to 12 lead here in a minute. So what we're going to talk about is this right here. I think this is where I'll probably go to the TV screen, so hang on. Okay, I think I've got this figured out. I don't necessarily need to be on TV. You guys don't need to look at my bald head. It just messes up the way you look at TV anyways because it shines a weird reflection. So let's carry on. We're going to look up for that. Now, there's multiple ways to look at 12 lead, okay? I'm going to show you one way. It's the way that I use. I believe it to be very simple, but someone in class pointed out another way that appears to be very simple as well. But what we are going to do is, you'll see this, we're going to use this mnemonic of Lisa. Several of you may already know this, but what we're going to do is look for specific injury patterns or infarction patterns within the 12 lead, and this is going to be kind of our location kind of a map, so to speak. So we're looking at lateral is our L, inferior, septal. I know this is messy, I apologize because I'm writing right over letters, but I'm saying it also. And then anterior. Now remember, as we get into some of this, you're going to see you can mix and match some of these guys. So you may have an anteroseptal or things like that. So once again, you have Lisa right here. Now, the way that I like to do that, and it looks kind of wacky, some people have already fussed at me about it, so you don't have to do this if you don't want to. But the way that I do it is I do an L. Now, you go through here. Now, in a weird world, I know I've been told it looks like a pipe. In a weird world, that's an L. Okay? Here's your I. Here's where I mess up. Oh, I think I got it that time. That's kind of a weird I, isn't it? So we got an I. Here's our S. It's just marking which leads are what. So, if we see, let me break this down for you. This is Lisa. She's very nice. Lisa, L, right here, okay, L, I, S, and then A. What we're doing is when we look at a 12 lead, and what I did as a new paramedic, and even when I'd start forgetting stuff and have to kind of review my stuff, is I would go through and mark my 12 lead with this marking. And what you do is you're looking for what? You're right, if you guys said elevation or even depression, right? You could even be looking for depression. But we're looking for elevation, we're looking for EKG changes, okay? So when you go through, remember earlier we talked about 2 or more contiguous leads. You have to have those changes to for that to be consistent. So in leads, for an inferior, if you have elevation in lead 2, and in lead 3, that's 2 or more. That counts. Now, what you should expect also is some reciprocal changes. And you'll find that table 17.8 in your book has that listed. Reciprocal meaning you're going to see basically the opposite. So in leads 2, 3, and AVF, you saw some elevation. So in your reciprocal leads, or leads 1 and AVF are your lateral leads, you would see more than likely you're going to see some depression. It's not that you have to, it's just that you can. Now, this is an important concept though to help identify this stuff, is to one, look for elevation right here in certain areas, and then to match it with your reciprocal leads of your depression. Okay, so I don't know if this makes any sense to you, but we're going to talk our way through a few of these things, and we'll kind of mark it up, and I hope this makes sense. Once again, I'm just going to draw right through it, okay, because you guys can't necessarily, I know you can't see me, you can just see the screen. So, once again, this is our L, this is our I, this is our S for septal, and this is our A for anterior. Okay? Big mess. Big mess. Apologize about the mess. Hopefully it makes sense. If it doesn't make sense, then obviously shoot me an email or come into class anytime that we're having class Monday, Wednesday, Friday, or when you're here for ACLS. Let's talk about it. We're going to have several guys here that day as well as myself. So one of us will be able to explain it to you, hopefully in a way that it'll make more sense for you. Let me erase all this because it won't let me carry on. So, reciprocal changes, here's what we talk about. You see reciprocal changes. So here's what we're talking about. We have, so our facing leads are like the leads that we're looking at. Reciprocal changes are where we should see those, kind of those opposite changes. And then your coronary artery involved, so your right coronary artery or circumflex right there, your LAD, these are where that's involved. Now, this is one, unless you have, I think it's the LifePak 18 maybe, or monitors in the ER, you're probably not going to have something like that. So you're not going to be able to do those posterior leads. Now, the V4R, anybody can do that, and what you do is, if you don't already know, you'll replace V4 off of the left side onto the exact same place on the right side, reshoot the 12 lead, and that's your 12 lead with V4R. Make sure that you designate it that that's V4R, not just your regular V4. So you can read about the mirror image. Essentially what we're talking about is, I have to look, V1 and V2. So in V1 and V2, you can take your EKG, you can invert it, and then look in the mirror, and you should, if you're having issues, you should see a Q wave and ST elevation in the V1 and V2, and that's going to be that mirror test that it's asking about. Now, let's have some fun. I know that's what you were just thinking. This looks like a lot of fun. So it's fun in a weird way, right? Now, this is probably what you're going to be more used to, is this guy down here, because you see, the thing I like about this is you have this long lead tooth strip. So you're able to really diagnose your rhythm off here, because up here is going to be hard to diagnose your rhythm, right? Because you've only got a matter of 3 or 4 beats. This guy has a rate of what, 3, 150, 175, 60, so 65, something like that. You're only seeing 3 beats. So it's, talking about this one, it's going to be really hard to diagnose that. But when you get down here, you're able to look at your whole strip. So let's go ahead and mark this thing up. What do you say? Let's talk about lead 1 here, ABL 5 and 6, okay? So here, there's our L, in a really weird way, I know. And now we're going to go over here. There's our I. That's even better than our first one. Now we're over here at V1 and V2, our S in here. And then 3 and 4. Sorry about that. Felt right. And then our A for anterior. I'm just going to make a quick little mark here. Lateral, inferior, septal, and anterior. That's what we're talking about, kids. So let's go ahead and look at this guy. So we can start however you like. I like to just go ahead and start at the beginning. And it's Lisa, so we'll start with our lateral leads. So look here. I don't really see anything there. AVL looks, it's kind of messy. It looks like it's broken up there. It's hard to tell. I don't see anything. 5 and 6. Let's see. They all look pretty normal, right? Now we go to 2. Whoa. Looks like we got some elevation. Huge amount of elevation there as well as there. So that's not good. Got a lot of ST elevation. Now, let's go to septal over here. These guys look pretty normal. And anterior, 3 and 4. So what I would think is we have an inferior MI. Here we're starting to develop, as you can see it right there, starting to develop a Q wave. We have all of that elevation. So we've got some issues there. So we'll talk about it here in a little bit, but when we get down later in the chapter, but we're going to follow that mononeurotic. You've probably already heard that. Morphine, O2, nitro, and aspirin. Of course, it's not necessarily in that order. We should probably be putting O2 on somebody first if they need it, way before we worry about this other stuff. So one more to look at for this. So we decided shoot them like that. And now once you get good, you don't really care if it's sloppy or not. So it takes you about 15 seconds to mark that up. So let's go ahead and look. 1, AVL, 5 and 6. That looks like maybe a little ST depression. 2, looks like we've got a, I'm trying to see where I'm at here. No. There we go. Yeah. So 2. Don't really see anything really. 3, AVF, kind of marked all over that one, didn't I? Looks like maybe a little bit of of depression maybe right there. Going up to V1, because we followed, we did our lateral, we did our inferior. Now we'll move up to septal up here. Now, you can see that. We've got a lot of elevation. Oh my, that don't look good. You don't need to be a cardiologist to figure that one out, do we? And, so we did 1 and 2. Once we get down to V3, holy moly, that's a mess as well. And V4 is all jacked up too. So now, earlier whenever I talked about that sometimes you get these crossed up, crossed up meaning mixed in together. I don't know what the right word is. Crossed up is probably not it. This is one word though, anteroseptal. So, because we involved our A and we involved our S. Now, if you wanted to, I don't think you'd probably say septal antero. I've never heard that before, but you can call it however you'd like. Just understand the anterior portion and the septal, the ventricular septum has been injured and infarcted. We're moving on into that direction anyways, isn't it? So, once again, that is our Lisa way to do this. I hope that starts to make sense. We're going to work on a little bit more, but it's just a matter of time on task. You guys have heard me say time on task a number of times, and you're going to continue to hear me say it. So, it's just time on task. Here we go. Let's go ahead and mark it up. So, sometimes you can just do that if you'd like to. There's that. There's that. And there's that. So, let's take a look at each one. Oh my, that ain't good. I mean, really slow rate as well, isn't it? So, got an elevation there. We've got elevation here. What about 5 and 6? Oh yeah. And yeah, we got elevation all over that. Inferior looks fine. Maybe a little depression as well. And septal, this is kind of weird looking. I think that's just a glitch in the monitor. And then 3 and 4 all look good. Maybe actually a little bit of depression. So, what would you guys think about that? If we are looking at that and we see elevation in leads 1, AVL, 5 and 6, I'm going to call that lateral. How about you? Looks like a lateral injury to me. Now, moving on down. Here's one thing that might throw you off. At first, when I first glanced at this, I thought it was just messy, that there was a problem. Well, here's the thing. This has V4R on it. So this is one of the newer machines that you're able to get. You're able to connect V4R. You don't have to actually take V4 off and put it on the V4R. You have LNR, I guess, left and right. So what happens a lot of times is if you find elevation in 2, 3, and AVF, which we know, now that we know, is going to be inferior, right? 2, 3, and AVF, that was the I, inferior MI. Then they found, I forget what the exact number is, Dr. Dubins had said in his book that it was like 40%, maybe even greater, of inferior MIs also had some right ventricular involvement. So now we do V4R. Now I'm not sure what they determined was if they were having a right ventricular infarction because of the decrease in preload, that if we were to give nitrates, it could potentially harm them. Talks about bottoming them out. Now, I've also seen newer research over the last year or two that suggests that may not be as accurate as they thought. So what I always say is you refer back to your local protocols when you're determining what to do. If you have a patient that meets the criteria to do the right-sided 12 lead, and then your protocol says to not do this or to do that, you just follow that. Hopefully those are vetted protocols and you'll be good to go. So once again, all of lead 2 under here. So 1, we've got this and this, this and this. Now let's take a look. Starting with our lateral. That looks fine. Looks like actually a little bit of depression. Right? You agree? Yeah, looks like some depression. And these all look okay. 2 and 3. So we see elevation, a lot of elevation. That's screaming, I'm sick. A lot of elevation. Septal, what do we see here? It looks, I don't think it's wide causing that. But so let's just go ahead and say we've got some septal involvement as well, it looks like, maybe. And then 3 and 4, it looks like we're back to the baseline, maybe. No. 3 and 4, but we've got a lot of elevation here. So when we say 3 and 4 on the left side, we're fine, but look at all that elevation here under V4R. So we've got all of this with that. So you would probably call that, I don't know how the best way you do it. You could either say it's a right ventricular or inferior with right ventricular involvement. And that's going to be, however you want. But make sure that you understand it is right-sided ventricular infarction, and that'll help you get through that. All right. I think I've got maybe another one. You guys are hoping so, aren't you? Nope. All right. So just to let you know, some of this stuff we're going to cover kind of quick. We're not going to go into some of these things really well. First, I'm going to get me some more water, so I've talked myself dry. All right, got me some water. Now we're ready to move on. So a couple things we're going to be kind of quick on. Other cardiovascular conditions, so benign early repolarization. It's a normal variant. You can see that benign is really the word here that should, what you focus in on. It almost is always a coincidental finding, which is something that you find secondary, characterized by ST segment elevation. Also has a J or a fishhook appearance at the J point. So remember that J point where typically your QRS ends and your ST segment begins. This now appears to take on a fishhook kind of morphology. Typically you're looking at V4 to V6 or even your inferior leads, and you'll have no reciprocal changes in this. So remember we talked about ST segment. We're going to look at 4 and 6. So we're talking about up here. V4 through 6. So we're saying one of the first things was characterized by ST segment elevation. Does appear to have some of that, right? J or fishhook appearance at the J point. So that's what we're talking about here. This kind of sloped, kind of turn way that it's built there. And then we're talking about 4 and 6. So typically no reciprocal changes as well. So we don't expect to see the opposites of any of this. Now, pericarditis, something to think about with pericarditis. When we look at 12 leads, we're looking at individual things, right? We see ST elevation in 2, 3, and AVF, and we know that it's inferior. We see it in 1 AVL and 5 and 6, and we know that it's a lateral, or V1 and V2, septal, whatever. So we don't expect to see it in everything. And that's essentially what we do with pericarditis. It's an inflammation of the pericardial sac. And when you see this word down here, this diffuse ST segment elevation, that essentially means you're going to see it kind of in a global fashion. It's going to be all over the place. You're going to have ST segment elevation. So some of the things about this is you might see, typically this is caused by infection or trauma, pericarditis is. So you typically have positional chest pain. A lot of times it's often alleviated by sitting forward, but it hurts if I do this and it doesn't hurt if I do that. Shortness of breath, history of recent fever. So we're saying that it is diffuse ST segment elevation, present in multiple leads. And then PR segment is elevated or upsloping, which I don't really say that you necessarily need to look into that. What we're looking for, though, is just that diffuse ST segment elevation. So we see it here. We see it here. So we got 1 and 2. Let's see. Looks like we've got some here, here. We're seeing it all over the place. So kind of just that globe. When we look at this global view, looking at all of these put together as one, nearly all of them have some ST segment elevation. So we would expect that the entire heart, that all of the coronary arteries did not get blocked all at the same time. So 12-lead ECG can provide information about non-cardiovascular problems. Pulmonary embolism, it can talk to you about intracranial hemorrhage, obviously some electrolyte abnormalities. Knowing what we do about the heart and how it works with the electrolytes, we should be able to understand that. Some genetic disorders that affect the heart. So the big thing with pulmonary embolism is going to be this pattern right here. S1Q3 T3 pattern. So what that is you're going to identify looking at a deep S wave in lead 1. Okay? That takes care of our S1. Deep S wave in lead 1. And then you'll have a deep and narrow Q wave in lead 3. And then you'll also have T wave inversion in lead 3. So this is going to be our waves. This is going to be our leads. That's this pattern. So S1, deep S wave in lead 1. Q wave, deep Q wave in lead and narrow in lead 3. And then T wave inversion in lead 3. So those are the things that we look for a PE. Also potential a new bundle branch block. And then you might see some ST segment depression on leads 1, 2, and 3. So let's take a look at this. We are talking about lead 1, right? We see that we have a deep S wave. We see a deep narrow Q wave in lead 3. A deep Q wave here. And then T wave inversion in lead 3 here. So that's what we're talking about with the S1Q3 T3 pattern, is that. Severe hypothermia, from what I understand, several of you have already been quizzed about the J wave. You will now be able to, if you didn't already, you'll be able to talk about the J wave if you quizzed again the next time you do some clinicals. But what this does is severe hypothermia can end up causing the heart and the body to develop some J waves. So it reveals a bradycardic rhythm and a baseline containing artifact. It can also be accompanied by ST segment depression and T wave inversion. But you'll see that this J wave or Osborne wave, it has a very sharp, distinct appearance to it, whereas with ST depression, we don't usually see this type of wave. So that's going to be your main difference whenever you look at that. Electrolyte imbalances. So hyperkalemia, many people talk about those tall and peak T waves. This is really what we're talking about when we say tall and peak T wave. Many times you look at an EKG and you see a little T wave that looks peaked or tall. It's not peaked or tall unless you stand out and stand and look at it and like, whoa, that looks like there's something definitely wrong with that guy. Then that's probably not a tall peak T wave. What we're talking about is this really tall and sharp peak T wave. So there was one other thing I was going to say on that, and I cannot remember what it was. Oh, P waves can become flattened, disappear. Hypokalemia. Now, just so you know, the main thing I'm going to ask you probably you need to recognize about electrolyte imbalances is probably hyperkalemia. We're going to cover all these, but don't go nuts on it and worry about getting everything down about the electrolyte imbalances. So hypokalemia, flat or seemingly absent T wave, development of a U wave, shortened QT interval when we're talking about hypercalcemia, hypo, lengthened QT interval. Cardiomyopathy. Hang on, where'd my page go? There it is. So in hypertrophic cardiomyopathy, myocardial walls become very thick. So it's a condition in which the heart muscle weakens, diminishing its ability to pump enough blood to the rest of the body. Main types of cardiomyopathy are named for the types of muscle damage each causes. So you have dilated, hypertrophic, and restrictive. So hypertrophic cardiomyopathy is a genetic condition in which the walls, the myocardial walls, become very thick, impairing ventricular filling. Patients will often experience some shortness of breath, syncope, all of those kinds of things, often associated with physical exercise. Often diagnosed in the patient's 30s and 40s. And it's characterized by deep, narrow Q waves in the inferior and high lateral leads, and very tall R waves in the left precordial leads. So remember, when we looked at, when we talked about ventricular abnormalities, when we talked about bundle branch blocks, then that's what we were talking about, right? Well, a lot of this kind of fits within, not bundle branch blocks. It'd be a long day already. Ventricular hypertrophy, when we talked about chamber, I can't remember the right word, chamber enlargements or something like that, chamber size, then we saw that, right? We talked about tall peaked R waves. We talked about long S waves. That's what we're looking at here. So we see that we have these tall R waves, these deep S waves, and it's because of all of that hypertrophy that is caused and the cardiomyopathy. Now, one of the downsides, you really see restrictive cardiomyopathy right here. The ventricular walls stiffen due to abnormal substances. So, you know, we've got these guys, man, these are people going to be sick. If they start getting sick because of this, you can expect that they are going to be sick. We're not going to go much into this. Brugada syndrome, disorder involving sodium channels in the heart, and a sense of why they would be sick from this. But incomplete right bundle branch block, ST segment elevation returns to the baseline. You might be able to see this in V1, V2, and V3. Long QT syndrome, so heart experience a refractory period that may create ventricular dysrhythmias. Long T syndrome, read about that in your book. I'm not going to go into it right now, much anyways. You can see administration of certain drugs, conditions such as hypocalcemia and MI, pericarditis. But here's an important one that we need to be able to recognize, and that is intracranial hemorrhage. So there's a couple of different things that you'll notice with this, with intracranial hemorrhage, and that is, so when you have someone that either has a traumatic head injury or, open or closed head injury or a potential stroke, this is something that you may recognize. So I'll ask you now, as you're working on the ambulance now, that you take a look at this stuff and see if you're recognizing these things. Hang on one second. Okay, I just wanted to check to make sure this stupid thing was recording. I had this sudden freak out moment that my last half hour hadn't been recorded. Anyways, we're good to go. So, intracranial hemorrhage. Inverted symmetric T waves in your precordial leads. We see here precordial. These are all our limb leads. See your precordial leads here. So we see how you have this inverted symmetric T wave and prolonged QT intervals. So that's going to be the main difference of what you see. So most of these patients will be unresponsive, or they're going to have some neurologic symptoms, obviously like some altered LOC, could potentially have some unequal pupils. All right, carry on. Cardiovascular disease. So according to AHA, cardiovascular disease is the leading global cause of death. Estimated more than 1 in 3 Americans have one or more types of cardiovascular disease. So cardiovascular disease of the coronary arteries and associated signs and symptoms, such as angina pectoris and AMI, characterized by the atherosclerotic narrowing and blockage of the arteries. So these guys have 5 to 7 times the risk of having a heart attack or dying. And that's characterized, as we said, by that narrowing and eventual blockage of the arteries that supply the heart muscle with blood. So, they may be asymptomatic, like I mentioned before. My mother went in, and they found out she was 90% blocked. She'd had a few little signs and symptoms over the last couple of years, or it may be someone that falls over, on the side of the road or whatever, and starts clutching their chest and all of that, anything in between. So it could be a scheduled deal or not. End of the day, though, it's talking about that narrowing and eventual blockage. So we're talking about, this is characterized, ACS, characterized by the diminished blood flow through the coronary arteries. Now, after that, you get an occlusion by a blood clot or a thrombus, or it can be characterized by coronary artery spasm. We'll talk about that in just a second. If you're already working ahead, talking about Prince metals, angina, things like that. And then reduction of overall blood flow from any cause. So it can be shock, dysrhythmia, pulmonary embolism, all of those kind of things. So what happens is, we mentioned it before, but if the blood vessel becomes blocked, those tissues are deprived of O2 and nutrients. So essentially, just like when we looked at our little evolution of MI, we start with what? Ischemia. And that's what happens, right? We move from ischemia into injury into infarction. So we start with ischemia, and then when that process is not interrupted, meaning it's not either sent to a cath lab, or they're not able to, that clot is not able to pass, or get a thrombolytic procedure moving on, or whatever, tissue death occurs, and we move into infarction. So atherosclerosis, that affects the inner lining of blood vessels, leads to the narrowing and the blood flow reduction through those vessels. So this process is as follows. Small amounts of fatty material are deposited along the artery's inner wall. Fat gradually enlarges and becomes a mass of fatty tissue. And then that mass of fatty tissue eventually calcifies and hardens into a lesion. The lesion infiltrates the arterial wall and diminishes its elasticity while decreasing the amount of blood flow. So it's not able to move the way that it needs to. It's not able to bend and all of that like it needs to, as well as it has decreased the amount of blood flow that's able to go through there. So that is the ideal site for the formation of a fixed blood clot, which can obstruct the artery altogether. And then calcium may precipitate into the arterial walls, causing arteriosclerosis, reducing arterial elasticity. And that's what they're finding out now. That's why you have all those heart scans, is how important calcium is in this process. Not really important, but I mean, that's where it's being deposited. And they're able to do that in those heart scans, really take a look at stuff. So risk factors: hypertension, cigarette smoking, diabetes, high serum cholesterol. All of these are things that we can do something about, right? They're modifiable for the most part. Male gender, family history, you can't do a lot about that either. But you have a couple of things here people can do something about. So you can do something to lower your blood pressure, even if it's nothing more than taking a pill, which is probably the last thing you should do. Unfortunately, it's about the first thing that most people do. But you can get out there and get moving and quit smoking and get off the diabetes, get off the sugars. The high sugars is what's really causing a lot of this. There's a certain side of the medical community that tell you sugar is really the cause behind a lot of this because of all of the inflammatory properties that it has. But that's a whole other talk. So let's move on. Modifiable risks: diabetes, excessive alcohol use, obesity, and smoking. So getting rid of some of these guys will help you considerably. Angina, principal symptom of CAD, cardiac, oh boy. I'm at a loss now, man, this has been long. Long day. Cardiac, I want to say atherosclerosis disease or something to that effect. So CAD, angina, is the pain that occurs when the oxygen supply to the myocardium is not enough to meet demand. So the cardiac muscle, once we know that the cardiac muscle becomes ischemic, right? And then once that happens, you have this low O2, switches to anaerobic metabolism, leads to a buildup of CO2 and lactic acid. So much like we talked about before. So during exercise or other physiologic stress, the patient may not have enough blood flowing to the myocardium to satisfy the increased demand for oxygen. So if the angina, So if angina occurs at rest, the patient has more severe CAD. That's the whole difference. So that's stable versus unstable, right? We know that if someone is out mowing their lawn and they expect that they're going to develop this chest pain, they have a little nitro with them, they take it, chest pain goes away, or they know that they start developing a little bit of chest pain, they're able to sit down 5 minutes later, chest pain goes away, shortness of breath goes away. That's all good. That's that stable angina. But when it's unstable, that's the bad part. That's the part that says this is a big problem. And we'll talk about that in a second. Stable follows predictable recurrent patterns. So every time you mow the lawn, and my pages are out of order. There we go. Every time you mow the lawn, then you start to get that shortness of breath or that chest pain. So you sit down, start feeling a little bit better, then you're able to finish the lawn. That's what we're talking about, stable. So pain occurs after a predictable amount of exertion. Maybe you need to take some nitro. Maybe you just need to sit there for a little bit. Now, if you were to look at this on the monitor, remember, if they're short of breath, a little bit low on oxygen, all of that stuff that's going on, we might expect to see some changes, right? We might expect to see some ST depression. That's what we talked about. The ischemia, we started out with ST depression, moved into elevation, and then we moved into a big old fat Q wave at the end. So we might expect to see some ST segment depression. But all of these changes, though, will go away whenever the heart's oxygen demand is met. So once we're able to get more oxygen in there, get everything firing back as it should be, then that chest pain will go away. Now here's the deal. Unstable, more serious. It indicates a higher level of coronary artery obstruction. So it's characterized by changes in frequency, severity, and duration of pain and other symptoms. More frequent and severe attacks, which may begin during sleep or at rest. So if the person's just sitting in the recliner and has a sudden onset of acute chest pain, that's way, obviously, more serious than if they were out mowing. Now, if they were watching their local football team and developed it, that's different. So that doesn't necessarily count just because you were in the recliner. One thing to think about, though, is this right here is warning of impending MI. So it's important that as this goes from stable to unstable, that we encourage people to seek help and get what they need to get before we end up having to run on them in the middle of the night because their body forgot to keep breathing. Prince metal, caused by coronary artery vasospasm, caused by chest pain at rest. It also has an increased risk of several things that you see there. It can be caused by a couple of different things. Emotional stress, hyperventilation, exercise, and cold weather. So you may see some ST segment elevation on the monitor. Most of this will take care of itself, or people may even use their own nitro. But with this, you do have an increased risk. You have increased risk of dysrhythmias, of an MI, of syncope, sudden death. So it's a little different because the whole idea is it is a coronary artery vasospasm. So it can be a little more serious. So the MI, let's cover this for a little bit, and then we'll probably shut her down because I've had a long day and I'm probably messing this up. So AMI, pathophysiology. In an MI, the heart attack, part of the cardiac muscle is deprived of the coronary blood flow. We know that all those coronary arteries is what feeds that heart, right? So if all of a sudden one of them becomes clogged up and blocked up, the thrombus, you're going to be depriving that portion of the heart from the oxygen and nutrients that it needs. So what happens is it's deprived of coronary blood flow long enough that portions of the muscle die. So once again, that's what we talk about where things like necrosis start to happen. And then you get that big word, that infarction word. That's not good. So location and size depends on which artery is blocked and where. So you see a couple of different things there, subendocardial as well as transmural. Most infarcts involve the left ventricle. When the anterior, lateral, or septal wall of the left ventricle are infarcted, it is usually from occlusion of the left coronary artery or one of its branches. The RCA usually causes inferior wall infarcts. Infarcted tissue surrounded by a ring of ischemic tissue, and I was thinking there was a good picture of that within our book. Let me see if I can get this thing on. I could maybe. It's not that it's anything that's going to blow your mind. So within this, we're talking about where am I at? surrounded by a ring of ischemic tissue. So what happens is you kind of have this I don't know how to say it, like an order of severity, okay? So here's our heart. So we're talking about this ring of ischemic tissue. So you have the infarction here, okay? And this is all colored in because this is jacked up. This is all dead. Then you have this other ring here. This is tissue that has not died yet. And then you have this other ring here of basically we're looking at, remember we talked about ischemia, then we talked about injury, then we talked about infarction. I have no idea why I just wrote 3 I's because it doesn't mean anything. But you have these rings of the injured tissue, right? So ischemia, which was low O2, right? We know that. And then you had the injury where things were starting to happen, and then the infarction toward the actual tissue was dead and becoming necrotic and infarcted and really bad. Remember, the things can't work. If all that happens, the heart can't work, the cells can't depolarize, all those cool and wacky things that we've learned about so far, none of that can happen like this. So, assessment. Whether STEMI is present, if so, notify the medical facility. So how do you know if a STEMI is present? Well, we're looking for ST elevation MIs, right? So it shouldn't be hard to figure that out. When you go and you run a 12 lead, you see elevation and 2, 3 in AVF, or you see it in 1 AVL and 5 and 6, then you should know that. Now, also, you can have a non-ST elevation MI, produces no sign of myocardial injury, meaning the ST segment elevation, but personal opinion from the point of a 15 or 20 year paramedic, as well as a FTO director and now an educator, that if just because your EKG does not suggest they're having an MI, trust your patient. If your patient is sweaty, diaphoretic, clutching their chest, they have a positive Levine sign, if they have a bad blood pressure, all of those things, and I don't care what your monitor shows you, it's hard to believe we've done this stuff without 12 leads for so long. But if you have all of those signs and symptoms and all those things that you're seeing with your eyes, and your 12 lead doesn't show you that they're having a STEMI or having a heart attack, it's okay. Run them in like a heart attack because they probably are. I know you've probably heard that saying about a duck. I won't tell it to you because I'll probably mess it up. But if it is a duck, if it looks like a duck, it probably is a duck, right? So determine the time of onset. Obviously, go back to our OPQRST. When did it start? What was going on? All those things. Look at the cardiac rhythm. Now, if somebody is having an MI, you need to understand you've got a couple of different things going on. You have a chance that you're going to lose this patient, so you need to be prepared. I'm not saying to put your fast patches on them, but you might want to have them handy, as well as have all of your medications ready and everything ready to go that you might need to. Transport to appropriate facility. Don't take them to the wrong place, man. Now, if your local protocol says you have to take them to the wrong place, that's between you and them. But hopefully, you are not forced to take them to the wrong place. Help them to make a good decision. Chest pain is the most common symptom, as you know, for an MI. You see this patient often clenches his or her fist when describing it. So that is that when you have your fist clenched, and I forgot to look it up, when you have your fist up, or a patient has her fist clenched and essentially holding it over the sternum, I think I've already talked to you guys about this maybe, that is a positive Levine sign. There is a statistic, and I don't remember what it was, something like 60% or something like that of these people are having an MI. So when you have a patient often clenches his or her fist when describing it, pain is just felt beneath the sternum, may be described as heavy, squeezing, crushing, tight. Pain can radiate to the arms, fingers, neck, all of that. Remember, because of the nerve, where they all innervate. The pain is dull and unaffected by deep inspiration, movement, or position. So if someone is having chest pain and they are complaining of localizing it in one place. If you push on it, does it reproduce the pain? So is it reproducible with palpation? Is the pain reproducible, or does it increase or decrease with inspiration or expiration? These are simple little tests that you can do to help determine whether it's pleurisy, so a pleuritic lung lining infection thing, or if it is actually a cardiac thing, because these signs and symptoms aren't interchangeable. So you can say, many of the signs and symptoms can be kind of looked at the same, but if you push in on someone's chest where they say that their heart hurts and it hurts their heart even more, it's probably not their heart muscle, because the heart doesn't feel pain like the rest of the body does. So that's why we're doing some of those simple little things. So that what I have here is a patient often unconsciously clenches a fist when describing the pain. That's Levine's sign. And then sometimes it can be mistaken for indigestion as well, and not influenced by body movement. It shouldn't, once again, pain shouldn't increase, shouldn't decrease, all of that based upon movement. So not every ACS patient has chest discomfort, so you get a lot of different things. Remember, we talk about this, you've heard about the silent killer, so you have the silent MI, and that typically short of breath type of thing, but you see all of these things that people can have, these complaints that they can have. Women, sometimes discomfort in the back, shoulder, and neck that can come and go. One of the biggest things that I've seen and read about would be dyspnea for women, as well as diabetics. Remember, diabetics feel things differently than people that are not, because of that neuropathy. Weakness, nausea, vomiting. Older adults, compromised mental status, generalized weakness. Diabetic patients, weakness, syncope. So take note of the general appearance. Take note of the LOC. Remember, LOC is going to be one of the first things to go. Pale, cold, and clammy skin. Vital signs. So signs of left ventricular failure, so wheezes or crackles. All this is based upon where the failure is, right, as to how it presents. Or signs of right ventricular failure, distended neck veins, pedal, or presacral edema. Let me see what I got here. Let's go ahead and shut this down, and we'll close this out on the next one. So we've been talking about the old cardiology stuff, covered a lot of stuff, and we're going to close this out on the next one. So talk to you soon.